Anyway, I have kind of a broad topic, but within it are several mini topics, and we've got 2 weeks to go through this. And so my topic was multiple organ dysfunction as it relates to sepsis. So what I've got is kind of a framework, and as I was putting this together, it seems to me that like this is kind of stuff we do every day, but put it in the framework of like ACLS or ATLS, where you go through the actual steps and what the examiner is looking for. So I think it's a fairly broad overview and just hitting the high points, but it seems to be kind of some high points that would be picked up on the test. In reading this, the SCORE topic was pretty tough, reading it within SCORE, and it seemed it kicked you off too up to date a lot. And I'll put in my plug-in right now for this book. This is the Washington Manual of Critical Care. And the little symbol, the Walters and Kluwer that is at the bottom, it's the same stuff. And so if you are in a situation in the ICU or at night or something like this, this is a great book. There's one in my locker when I'm not putting together a lecture, okay? But what it has is a lot of algorithms and stuff that are really drilled down into kind of nice teaching and thinking points, okay? So we'll just kind of start. Multiple organ system dysfunction is a syndrome of progress. Probably 40 years ago, which to y'all sounds like a long time, but to me, not quite as long. These people just died. I mean, 40 years ago, they didn't even feed people in the ICU, and we're pushing to do that within the first 24 or 48 hours. And so these patients that didn't get ventilated or didn't get adequate volumes just died of kind of overwhelming multi-organ failure within a brief interval. And you can see this is only as far back as 1975. I don't know if y'all know Dr. Hiram Pohl. He's a big guy at Louisville. But that last point there is remote organ failure was a sign of occult intra-abdominal infection. That doesn't seem that long ago for that to be, kind of be putting together. And I guess that's bowel, I'm not sure how to say that. But these multiple organs failures may not proceed in a direct sequence, but they were all clinically related. And so sepsis is the #1 event. So I didn't, if somebody asked me to define sepsis in a couple of sentences, I couldn't even do that before I started this. You're like, well, I kind of know, it's fever, tachycardia, tachypnea, leukocytosis. But there's a little bit of controversy as far as the actual definition, if you had to put it in just a few words. But what it is ultimately is a dysregulated inflammatory response to infection or some insult. And they always throw in their burns and pancreatitis if it's not an infection. So that's just an explosion of inflammation going on in your body. But, as any wound healing, inflammation is part of the healing process. But when that becomes overblown or lasts too long or something like that, that's when we kind of need to get into problems. So if it's prolonged or uncontrolled or not reversed, it can lead to a multi-organ failure, and you can kind of think of it as an auto-destruct sequence. Okay, so one thing to remember is the lungs are usually the first ones to go. Anyway, and again, it doesn't proceed necessarily in a sequence. And it can happen regardless of the inciting event. So the treatment are kind of regular things we do anyway. It's fluids, antibiotics, drain the abscess, resect the dead bowel. They're just kind of supportive measures. If you need to fix their potassium, you fix that. Start nutrition and that kind of things. And in studying and preparing this, this is kind of taught as an isolated event. It's not like our patients, hypertensive, diabetic, morbidly obese, smoker, alcoholic. So all that stuff's kind of going on too in the supportive measure. Okay, so this is taken directly from SCORE, and it kind of gives you the stepwise definitions as it kind of gets worse. Bacteremia is just it's just bacteria in the bloodstream. It can happen after you brush your teeth, right? So that's kind of the lowest end, and it may not be clinically significant. Sepsis is the overreaching inflammatory response, and kind of the first signs are fever, leukocytosis, tachycardia, and tachypnea, which may be fairly subtle, and it may be a normal response. You have to be aware and have your ears kind of perked up to kind of be looking for this. Severe sepsis is sepsis plus at least one organ failure. And again, it doesn't have to be at the site of the infection. It doesn't have to be a pneumonia that pushes you over into sepsis. And septic shock is hypotension with the organ failures that is refractory to kind of treatment measures. And so we'll go through kind of what's expected as far as the treatment. This is Another slide taken directly from SCORE, and these are kind of what you'll see. You may or may not see. I hope you don't see all of them. That would seem like kind of a terminal event. But in general, what you're wanting to do is get these back into normal parameters, okay? We don't even use swans very much on the cardiac service, so we usually use a flow track, but if they're tachycardic or in AFib, that really doesn't help you so much. But these are numbers that are kind of the abnormalities that you want to look for and start kind of fixing. Probably the only one that will really stand out on just general labs or platelet count, and it's the only one with the poor prognostic factor in sepsis. Okay, we see that all the time, and they'll kind of drift down, 400, 300, but as they get lower and lower, you got to think about your heparin that you're on and things like that you're doing, but it is a bad prognostic sign in sepsis. The mortality, just plain sepsis, no organ failures. Just the fever, tachycardia, leukocytosis from something else going on has a 15% mortality. Severe sepsis, and this is something you can use, regardless of what you're treating. This is what I quote to patients when they develop renal failure or something like that. Kind of per organ system that fails, that's a 25% mortality, and they just add up. So when you got somebody that's just, undergoing apoptosis in the ICU, these are the numbers you can kind of use for your family as you're discussing them with them. But if you've got 3 or 4 organ failures going on and you've got an 80-year-old man who hasn't died yet, things are probably not going to go our way. So that gives you some information for your patients. But septic shock, 40% mortality. The etiology, kind of the best prognosis is if it was from a line or a urinary tract infection, and it's much worse if it's an intra-abdominal or a pulmonary source. Okay, gram positives always first. Gram negatives are becoming more of a deal, and certainly in our field, intra-abdominal sepsis, gram negatives. And fungal, you have to think about that with somebody, of course, that's immunocompromised or been in the ICU with something else going on for a long time. And with the early treatment with antibiotics, you're supposed to get that first dose of antibiotics in within the hour, once you kind of diagnose this and go. But you may not identify an organism. Septic shock is when you have hypotension that is refractory to a fluid challenge. And so what you have to think about, there's kind of, it's like a ventilator. You can increase oxygen delivery and blow off CO2. That's kind of the goals. There's multiple ways to do that. In shock, you've got cardiac output and systemic vascular resistance. So either one of those can be out of whack, and you may have to fix one or the other or both. And they always talk about warm and cold. Warm shock is going to have a low SVR, but the heart's still okay and pumping adequately. Cold shock is when they're both low. Okay? And so the early volume, the sepsis pop-up that's in Epic that's so annoying because it never goes away. That's where all this comes from. But the early volume resuscitation, you'll see numbers anywhere from 20 to 40 cc's per kilo. In preparing this, it seems to me that the consensus is about 30. So 30 cc's per kilo. And you're supposed to get that in within about 3 hours. I'll show you the algorithm too, but that first dose of antibiotics, if you're thinking some sort of infectious source, that needs to be in within the hour. I mean, it's a clinical indicator and all that as far as hospital and quality and all that, but I mean, this is an emergency, so, get it in as fast as you can. That'll be kind of pushing the nurses, perhaps calling the pharmacy, but you need to get that stuff in. And they're being watched just like us. But I mean, ideally, surgeons, trauma stat, whatever, we want everything done just as fast as we can. So this is not a patient that you write some orders and disappear for 6 or 8 hours. This is from my little trusty book, my critical care manual. These are your doses of your pressors and everything. But if you look at that, that's not a very big list. And that's what we treat septic shock with. And it's even probably shorter than that. I don't know many people are using dopamine anymore. We just go to norepinephrine. You make the blood pressure whatever you want. Vasopressin is kind of the second line. There's the new one that's the synthetic angiotensin that's available in this hospital. It's in here, and that kind of gets you down off of these doses. But Levophed, vasopressin are kind of old hat. That's what we use. Dobutamine if their cardiac output is low. And steroids, we'll get to that in a little bit. But I mean, that's kind of it. And if you can keep them from dying or having a myocardial infarction in the meantime, you kind of wade them through with just a few things and get them through it, okay? So I'll send this to y'all. These algorithms are handy just to have, in your pocket or something. But this is the kind of stuff that you'll review, right now in the 3 or 4 weeks before the ab site. But I mean, it's still stuff you're going to do every day in the ICU. I'm not going in on all that interleukins and cytokines and stuff you got to learn in the 3 days before the test. It's not practical knowledge. We're not going to need that stuff, okay? But anyway, those are your drugs to treat sepsis. That's a pretty short list. Uh-oh. I'm locked up here. Tyler, I think I'm in yours. There we go. Okay, so these are the Society of Critical Care Medicine's recommendations for surviving sepsis. You would think this wouldn't have to be their overreaching sepsis statement, but sepsis and septic shock are medical emergencies, and we recommend the treatment and resuscitation begin immediately. Thank you very much. Okay, so I have those two if y'all like me to send it to you. The surviving sepsis PowerPoint that was presented, it's probably 100 slides. I would say 20 of them are what you do. Most of them is, you know, we look through these journals and this is level 1 evidence and all that, but it's an emergency. So, think of a patient that they call a star donor in the floor, and then they end up moved to the unit, or this is somebody that's already in the unit. So this is an ICU patient. Patient should be moved to the unit if they're not there. It's kind of a medicine stat. Oxygen, maybe they need to be intubated. You need venous access to give these fluids, to draw labs, arterial line to monitor your response. I would say in general in this hospital, these people are going to end up at least on a flow track, right? Just kind of general labs that you're going to start. Procalcitonin is helpful. It's not going to really make any treatment decisions for you. What you'll do is follow the trend, and what it does is it kind of gives you an indication when you can stop antibiotics. You're going to look for a source of infection. Maybe it's not infectious. If they do have pancreatitis, they can certainly get infected pancreatitis. But you're going to culture anything that you've kind of done. You're going to culture wounds, lines, urine, Foley's, that kind of stuff, and some sort of imaging. Maybe it is just pneumonia, but if you're suspecting a pneumonia, you just need a chest X-ray or a CT abdomen pelvis. And of course, with that, you've got to weigh in. Do I need to give contrast? Do I need to hurt his kidneys more? Okay, so, you know, regular old general stuff, not a big deal. So we said earlier, lungs are first to fail. That's what you'd expect. I mean, you'll find the patient tachypnic in some way. And the goals of your vent and your volume support is get them back to normal. You don't need them satting, you know, 100% with the PO2 of 120. You just need them as close to normal as you can. So a sat better than 90, an oxygen sat PaO2 of 60, and a PCO2 of 40. Just back to normal baseline. You don't need anything super therapeutic or super fixed. So, an initial rapid bolus of saline or lactated ringers, 30 cc's per kilo within 3 hours. That's not too fast. You know, if you've got a 70-kilo person, that's 2 liters over about 3 hours. Not so bad. But it's not write 2 liters and walk away. It's like a burn resuscitation. We don't write fluids for 24 hours and walk away. They're in the ICU. They've got a nurse sitting there monitoring them minute to minute. So you'll judge your response. Antibiotics within the first hour. And again, your targets are back to normal. You know, this seems simple, that you give them some fluid and everything's fine. But it's not quite that simple. This is very drilled down to give you your goals. But a normal CVP, a normal MAP, urine output, mixed venous sat greater than 70. So that's an indicator that the periphery is being perfused, and a lactate less than 2. Unfortunately, that never goes off on epic, right, until they die or get discharged or whatever. And then just, you know, kind of clinical monitors of your patient. They made a big deal about the passive leg raise, and it's simple and quick if you're on the floor and you're not hooked up in the unit with a flow track or something. By raising their legs, you dump some venous return in, and so if their blood pressure goes up with something that simple, that's an indicator that they're going to be fluid responsive. Okay, so a passive leg raise, that's something quick and easy. Just raise their legs and repeat the blood pressure. In the meantime, give them fluids. All right, this is from that book too. It's not the best slide, but in that I took it with a phone and made a slide out of it. But anyway, this is the same thing. This is all this that kind of gives you your endpoints of what you want to do. So, you know, you've got these signs of sepsis. They've got an elevated lactate. Their blood pressure's low. First thing you do is give them fluids. Get their CVP up. They say 20 here, but I would answer 30, okay? course, it's going to be somebody with CHF. I don't think they would zing you on the test with somebody that's so clinically ill otherwise. But in general, I would say 30 cc's per kilo. Drive up their CVP. If they're still hypotensive, then you go to pressors. Okay? And then this kind of adds in transfusion. Normal transfusion triggers a hemoglobin of about 7. And some people are okay with that. I would say the surgeons are less okay with that than the medicine doctors. If I'm on pressors and my hemoglobin is 7, why not get the blood? Anyway, that's kind of a art of medicine kind of thing. But anyway, you need an adequate hemoglobin. So 7, 8, 9, 10, somewhere in there. I mean, at some point you're going to end up in pulmonary edema if you just keep giving fluid. So think about some blood too. And then we'll get over here and these adjuncts or steroids and things like that. So that's one of those things you carry in your pocket. But it's really, when you sit down and look at it, it completely makes sense. It's not that you've got to learn this is what you do. But it just gives you a stepwise fashion to go through. Anyway, this is the same thing. It is just the same thing. Depends on which way you want to look at it. But it's got your inotrope right here if you should need some dopamine. And they say hemoglobin up to about 10 with a hematocrit of 30. Okay. So, early insertion of your SCVO2 catheter, we kind of do that sometimes. Mostly it's fluids and the potential for, this is the 2016 update from the 2001 up to 12, but it's the only thing it really added was the dobutamine and maybe pushing the hemoglobin up a little bit, okay? So this is just repetition of what we talked about just a minute ago, and the recommendation is that it is protocolized, where it's not just, a second year coming by or maybe the nurse watching it or anything, but to have a discrete sequence. So that way, if you're busy, maybe the nurse can carry on with it. And all these parameters ideally are better by 3 hours and for sure fixed by 6. And that's assuming your patient's responding too. So again, not super therapeutic, a normal CVP, normal MAP, normal urine output, and a normal mixed venous O2. And that's what it is. Normal transfusion trigger is a hemoglobin less than 7 and consider transfusion to 10 if they're actively bleeding or having myocardial ischemia. Okay. Antibiotics, what you've got to cover is MRSA. Gram-positives are your most common organisms. And the most common other organisms are gram-negatives, Klebsiella, E. coli, but strep too. And you'll see in cultures, if you get back a positive culture, obviously you'll tailor your antibiotics at that point, but you may never get them. So then you've got to, find out when you're going to stop them. 10 days, 2 weeks, normal procalcitonin or something like that. These are the organisms you need to start with. So this would be us, And they don't really give recommendations as far as which gram-negative. A lot of here, Mirum's kind of usually the start, maybe Primax and Zosyn. Source control. This is another one that as soon as you can, handle the infection, start the antibiotics, drain the abscess, remove the dead bowel, whatever it is. And sometimes they're just, it's going to take a little while. You can get them to the operating room, certainly from a surgical perspective. But handle the source as quickly as you can. Pressors, start them when you need them. Once you've given the 30 cc's of fluid, you may have to give more too. You can gauge their response and say a little more fluid, a little more fluid. I mean, 2 liters honestly is not that much fluid in somebody that's got pancreatitis or certainly a big burn or something like that. So, you may give more than that initial 30 cc's per kilo. But if you're giving more and more and you're thinking, I'm about to dump this person into pulmonary edema, by giving them these fluids, you're either going to transfuse some blood or start some vasopressors. Number 1, and that's certainly our practice here, is Levophed. You can make your blood pressure kind of whatever you want. If you're on a big dose of Levophed, kind of second line is vasopressin, third line is the angiotensin. And with the angiotensin too, you can kind of come off of these. But vasopressin is kind of a bad actor in that you worry about myocardial and gut ischemia. Okay? So number 1, Levophed. And if their cardiac output is low, dopamine's a drug. All right, so we've got fluids, maybe some blood, Vasopressor, which means levophed, maybe vasopressin, and dobutamine. You got 5 drugs to keep up with. Okay, here's the one that surgeons don't like, steroids. We always get kind of anxious about those and everything, but there's the whole body is just a great big ball of inflammation in these processes, so you've got to get control of that. The only way to do that is steroids. I mean, we worry about wounds healing and that kind of stuff. However, you're not going to live long enough for the wound to heal if you're having an Addisonian crisis. So here I've got you an algorithm and all for your steroids and all that. But when you consider steroids, you've got to be thinking about it too if the patient was already on steroids. And maybe that is simply what the crisis is you've withdrawn it, and that's why they're having these problems. But if it's their septic response to whatever insult, you need to think about it if you've given them adequate volume and you're on pressors and they're still hypotensive. Now you've got to rule out that they're having, congestive heart failure because of the MI and all that. And you can't take just these in isolation. And these ain't going to be the patients at the hospital that they've got one thing going on, right? And so it's going to be, a terribly sick medicine patient that has something like this. So we've got to think about steroids. But you fluid resuscitate the 30 cc's per kilo, do your pressors, and then your steroids, you want to shoot for a goal of 200 milligrams a day divided to QID. Okay? Plain old hydrocortisone. Adrenal insufficiency. So it's got a cute little name now. Critical illness related corticosteroid insufficiency. Addisonian crisis, something like that. But the cortisol should rise in response to your surgery, whatever illness you have, whatever's going on. But for some reason, that doesn't happen. So it's a relative adrenal insufficiency. They're probably not dead, unless there's been some kind of terrible episode of hypertension or something like that. But there's an inappropriate lack of response with cortisol in critical illness. So these are why that would happen. Trauma, infarction, ischemia, hemorrhage, malignancy, so that's a direct primary insult to the gland. Or the secondary, discontinuing exogenous steroids. We don't see that a lot. You'll see with like a Crohn's person or somebody that's got one of those weird bone sarcoids or something like that. Or head trauma is probably what we're going to see. But I would say most of them are just going to be just lack of response, kind of a relative ischemia where they're hypotensive. Again, that's just to reiterate it. Think about steroids if you've got someone that you have volume resuscitated and you're on pressors and you still can't get their blood pressure up. So here are the normal actions that you would expect and how the lack of them creates a problem. So it increases blood sugar levels to provide fuel to the cells. It increases production from the liver, peripheral insulin resistance, hyperglycemia is risky. Hyper and hypo. I mean, again, ideally they stay right in the normal range, but that's usually not going to happen. But if you exhaust what you've got, you would expect hypoglycemia. It helps with kind of your blood pressure, your endogenous blood pressure control, and again, when you add these pressors, where it facilitates the cardiovascular response to epinorepinephrine and angiotensin II. We can provide all that in an IV, but ideally the body's going to handle it itself. And it has anti-inflammatory effects. Okay, so if you don't know, and you're thinking I need to give these people steroids, there's a gauge of somebody that you would expect to respond. So what you'll do is you want to draw a baseline cortisol. That's just a lab draw. It takes a few hours to get back. But if it's already low, you know you're low. You're going to have to replace that. If you want to bother with the cosentropin challenge, you draw the cortisol, you give the cosentropin, and then you draw another cortisol about an hour later. You would expect the cortisol to go up more than 9. All right, those are tough numbers to remember. Again, there's an algorithm in this book. But, you know, you got your lab ranges in there. But it should respond if it can, okay? What you're looking for is an adrenal gland that cannot respond. But I would say, you know, controversy of one or both is necessary for diagnosis. If either one of them's out of whack, you're going to start, right? You've already started steroids. And then there's this trial, Corticus. If either one of them doesn't respond, you know, you got a problem. You expect a longer duration of shock and perhaps death. So if you treat them with steroids, you have a less risk of death. And the dose is 50 milligrams 4 times a day for 7 days, so 200 milligrams a day. Here's the algorithm. It looks a lot more complicated than it is, but honestly, if you sit down and study these 3 or 4 algorithms that I'll send to y'all, I mean, it makes perfect sense, and it gives you a framework to take care of the patient and to take this test that's coming up in a month. But it just kind of walks you through that. If you, where is it? It's down here at the bottom. These are those 2 levels. If your cortisol is less than 10 or it doesn't respond, adrenal insufficiency is likely. If they're both kind of in the high or normal range or an appropriate response, the adrenals are working. In addition of steroids is not going to help. This is the insulin control stuff. This kind of goes along. If you're providing with steroids, you'd expect them to be hyperglycemic. But this first came out in cardiac surgery where those first 24 hours of hyperglycemia were noted to have an increased risk of sternal dehiscence and mediastinitis. Cardiac surgeons don't like this because target range of 150 to 80 is kind of okay. But look at this note. Somebody stayed up late thinking this out. The NICE sugar trial. Normal glycemia intensive care evaluation of survival using glucose algorithm regulation. What they figured out, if you try to control it really tightly, you'll have increased episodes of hypoglycemia and increased mortality. Okay, so we will accept or shoot for a goal of 150 to 80, which is, that's not that hard to kind of shoot for, and that's a little bit more reasonable, trying to get a sugar in there. And it may be too, if you can control their sugar, they're responding to your other treatment. It's not just controlling the sugar that is the goal, is that they're getting better because I can control the sugar. But remember, less than 200, we're happy around here, right? Yeah. All right, so that was that. So fluids, pressors, maybe blood, steroids. So then our other organ system that we want to talk about is neurologic dysfunction. And this is outside of kind of head injury and trauma patients. These are patients that, you came in for something else. You did a colectomy on them for colon cancer, and now they're not acting right. So in general, if you can remember, delirium's bad. Okay, they're hard to take care of, and it doesn't help anything. So the definitions, this is another thing. We see it all the time, but putting it in words, it's hard to do, or, nobody takes the time to do that. So you have delirium and dementia. Dementia is a chronic problem of cognition, okay? And delirium is an awareness kind of problem where the sensorium's messed up. So delirium is an acute event. You can have dementia and then tip over into delirium, but delirium doesn't turn into dementia. But delirium is an acute change in cognitive function affecting attention, arousal, orientation, and perception. Think somebody in the ICU is going crazy. Okay, that's what it is. They have altered consciousness with reduced ability to focus, sustain, or shift attention. And it's not necessarily an even curve or anything. It's fluctuating throughout the day. Sundowning at night, right? Everybody's sicker at night. Hypoactive or the quiet sleeping, but if you wake them up, they're disoriented. Just think of the little old man that came in with like a perforated ulcer. Here he goes. And there's the hyperactive, where the ICU psychosis, where they're going crazy. So it can be either one. But you got to figure out what's going on. And like I said, it makes everything worse. And sometimes it's unavoidable. It's just going to happen. And you can predict it when you see them in the ER. Just makes everything worse. So it's an independent marker for mortality at a year. And some of these cognitive impairments may last a long time, or they may last forever. You'll see these young guys that have it in their 30s and 40s. They kind of go to the rehab and they come back to clinic and they're a different person. But some of these older people, it's not going to get better. It's kind of plinking over the first domino and everything just goes from there. Okay, so dementia is chronic in cognition. Delirium is sensorial. And so this is kind of to perk your ears up as you're seeing this patient before you ever do anything to them, certainly surgically. What kind of patient are you starting with? Do they have dementia already? What medicines are they taking that you got to worry about getting them back on afterwards? Because ideally you keep everybody at their chronic state except for what I did for them. Can't eat for a day or two, but I'll give him all his medicines IV or however. But you want to get patients back to where they are as close to their chronic state as you can. Kind of the things that you need to look for and why they're acting like this is you want to look for signs of infection. I mean, that's probably one of the most common one. Hypoxia, that's usually pretty easy to figure out. You would expect them, if they can, to be more agitated and anxious if they're hypoxic. So look for signs of infection, hypoxia, just a little bit of hypotension, hypoglycemia, and do a neuro exam looking for maybe this is a stroke and not delirium. Okay, treatment's different. Review their medications. What are they supposed to be on that maybe we missed, and getting them back to their usual state. Could be a withdrawal, or it could be something that you've added. Regular, just kind of things to check. Looking for infection, and pneumonia, hypoxia, toxicology. That certainly you would think a younger patient, but you'll see some older guys that are taking some stuff they're not supposed to. And think about, if you can, maybe they can have a regional block, just a little local, and not have to have general anesthesia. So that's kind of just, none of that is written in stone, but that's the kind of things you do, trying to plan out what you're going to do to this patient. And your treatment goals are try to get them, don't hurt them, get them back to their usual state. Get your hydration and nutrition where it should be, get them up and moving. That's kind of come to the hospital too with that, what is it, get up, stand up, whatever it is, that mobility thing. But if nothing else, don't let them lay in the bed and sleep all day. Of course they're not going to sleep at night if they catnap all day. Wear them out during the day, maybe get them on a day-night cycle, and sleep. Treat pain, and again, treat pain with narcotics. Narcotics can cause delirium. So, everything is risk-benefit, weigh your choices. Prevent skin breakdown. Don't make something that you're going to have to go to breed or can get infected. Incontinence, don't let them get a UTI. Don't let them lay there and poop. Clean them up. Minimize risk of aspiration. All right? Try not to let them get sicker than they are. Same thing. This is kind of nursing stuff here, but things you need to think about. Try to keep them in as usual of a state as they can. Hearing aids, glasses, pictures, family to stay in the room and help you wrangle them and keep them oriented. Day-night cycle. You see this every time in the ICU. I certainly see it in the burn unit. We ain't got no windows. At least in the SI, you've got a little bit. But, for the night nurses, it's their day. The lights are on. They're making all the racket. Nobody's sleeping in the unit. So, avoid restraints. That's hard to do. I mean, certainly you don't want to tie somebody up. That'll slip them over to that hyperactive state. And then, kind of treat whatever they need. Whatever's going on, take care of that and try to get them out of the hospital. We're at 21 minutes. Okay, here's our drugs. Probably the biggest thing is Haldols are treated. But you've got to think about, is there some medication that was stopped that we missed, bringing them in on their MAR or something? Is this just alcohol that maybe he wasn't up front with us when he came in? Usually the family's helpful with that. But pain can make it happen. Treating pain with narcotics can make it happen. So, if you can get away with some anti-inflammatories or a little tiny scheduled dose of narcotics, something like that. But Haldol is still the first line drug. And it's better to give a tiny scheduled dose rather than PRN, where you have the spikes, if you can even them out. There are these other drugs, but none of these have been proven to be any better. We usually at this point have consulted psych, and they'll try some of this stuff. But you can overshoot with these too. Kind of the bad drugs to think about, or what you would like to seriously avoid, are benzodiazepines and Demerol. They're kind of the group in the one that you think about of tipping somebody over into delirium. And there's some trials going on now with gabapentin and melatonin. Melatonin, for those people that take it and like it, they love it. That's it. It didn't work. Didn't make a change. Okay, so I think this is my last kind of subject for today. This is something I don't do a lot in the burn unit, and I certainly haven't done this since I was the second year in the unit on trauma. It's probably the people that do it the most. But just to review it, and actually we had a standardized patient scenario of this a couple of years ago. But if we're talking about brain death, just as a reminder, it is irreversible. Do not offer the family any hope, okay? They're not going to get better. There's those miracles you see on Fox News and stuff like that. Hopefully we'll never have that. But there's kind of three parts of it, okay? So it's an irreversible coma of known cause. There's loss of all brainstem reflexes, and there's no respiratory drive. So if you don't have those, you may not be brain dead. But those are kind of the three. What we're going to see here, trauma, post-code, or cerebral edema from, kind of a multiple sources, but probably fulminant liver failure is probably one we'll see. But we don't take care of those patients. So those three parts are the brain death criteria. These are terrifying, but these are things that you have to kind of think about that could also be going on. These are not going to be on the surgery service. I guess somebody could have some kind of crazy stroke or something like that. But the locked-in syndrome, where they are unresponsive, unable to move, they may have some eye movements or blinking, but in general, there's nothing there except there's EEG activity. Okay, and this one kind of surprised me. Severe Guillain-Barré, where they can lose all function. Those two are terrifying. That would just be the worst. Anyway, okay. So these are the things that you've got to fix before you start assessing for brain death. Again, these are going to be on the trauma service in general. You're not going to have some patient come in for a colectomy that gets septic, and then you're looking at them for brain death for an organ transplantation. But these are just kind of regular things that you want to fix. Hypothermia, somebody found down outside, can happen even in our climate. Drug intoxications, and that may be drugs that we prescribe. We've got them paralyzed, we've got them sedated from the vent. You've got to allow time for that to kind of burn off before you can do these assessments. Hypoglycemia, hypotension, they may need pressors to kind of support them while you're figuring this out. And fix electrolytes and acid base. Okay, so the comatose state, this is how you start kind of looking. And I've got the checklist and Epic in here too, because again, I haven't done this in a while and hopefully won't have to. But there's actually, it used to be just a paper thing we checked off, but there's a discrete checklist in Epic. How far apart do the two exams have to be? 4 hours, 6 hours? Some people say an hour.
It's like depending on the hospital, they make their own stuff.
Yeah, and it's one of those things where you practice is going to determine that. But you got to have two exams some interval apart, two separate doctors. And so no motor response to central noxious stimuli. Because again, if you pinch their big toe or something like that, maybe they're just paralyzed or insensate, they can't feel that. So it's got to be central. And so you pinch their supraorbital ridge, jaw thrust, something like that. Something in the midline that would kind of hurt. Cranial nerve territory, no pupillary light response, no corneal reflex where you touch the cornea or brush the eyelashes, and cold calorics. I had to look that up. I hadn't done that again. I remember something about the eyes, but I had to look that up. But I've got a little picture of that. And no cough with deep suctioning of the trachea. Suction the trachea, jiggle the trachea, make sure there's no response to that. Because they shouldn't do anything, right? They're dead. The machine's keeping them alive. So there should be no response to any of these. The cold calorics, I couldn't remember what this was, so I found a picture. And what you do is you squirt the cold water in the ear, and the eyes should, so in brain death, nothing's going to happen. But what you would expect if they're not brain dead is the eyes deviate toward the water and the nystagmus is away. Okay? But again, we don't care if they respond, okay, they're not brain dead. What we're looking for is no response, right? In the doll's eyes, what should happen in a normal person, when you turn the head, the eyes go the other way. When you're brain dead, nothing happens. Okay? So what happens in brain death is nothing happens, right? So if they ask you a normal, which they won't, just remember it's the other way. So these are in Epic, and these are all yes, no, click-off things. I had to look this up, but these are all kind of the same things. The one that I want to talk about is the apnea challenge, because you've done all the doll's eyes to make sure they don't gag when you jiggle their ET tube or something like that. So how to do the apnea test. And so what you're trying to do is stimulate them to take a breath based on hypercarbon. So just kind of the logistics of the test. You pre-oxygenate with 100% oxygen. Okay, so you give them some reserve so they don't crash and immediately die. Or if there's something there, something will happen. You draw a baseline CO2 after that hyperoxygenation. And you need to get it, if you can, in the normal range. Maybe they have some underlying respiratory issue to where you can't, but you get a baseline CO2. Pressors, volume, whatever, to give them a pretty normal blood pressure. Okay, let me go to the next slide. This is it. So you pre-oxygenate them, you get a blood gas, you check what your CO2 is. You take them off the vent, and you put a suction catheter down the ET tube, tape off the thumb hole, for the oxygen just kind of blowing down the airway. Usually about 3 liters, you can go up if you need to. And you observe for respiratory effort for 10 to 15 minutes. That's a long time. If they drop their pressure, you got to stop the test. If you need to give them a little bit of pressors or something like that, or adjust their pressors while they're going, you can do that. But if they're desatting, they failed the test, okay? So you observe the chest for 15 minutes. I've seen people lay a little vial of saline on it. You'll see the water jiggle to help you look or something like that. It's usually pretty obvious that they're not breathing. You can look on the vent tracing and see that too. But shouldn't do anything, right? They're dead. Should not happen. And so then you get another gas. And so what you want to prove with that gas is that their CO2 went up. It should go up to 60, a normal person, or you're looking for a change of 20. Okay? And so that should be enough of a stimulus to make them breathe. Okay? And if you can't
So when we've done this in the past, the respiratory therapists, they calculate something, and they'll give you a time period. They're like, it should raise in like 4 minutes, and sometimes they'll do it only in 4 minutes. But they told us that as long as it gets above that 60, is that okay?
Yeah, if you want to get it to that 60, but then again, if you've got an abnormal that it's not in that 35 to 45, it's got to go up 20.
Yeah.
Okay, so yeah, I don't know that calculation, and I hope that's written down somewhere in one of our protocols. But anyway.
It's in a template, so.
Yeah. So anyway, but what you're trying to do is get their CO2 high enough to where there's a stimulus for their brain to take a breath. Okay, that doesn't mean that they don't have some devastating neurological injury or insult to where they're never going to be the same, and then that's a whole different discussion with their family. Okay? So, I think that's all I have right now. Yeah, that's all I have for today. Okay? I will send these to you so y'all can have these algorithms. Next week we talk about like kidney failure and liver failure and that kind of stuff. Okay? Good luck on ABSITE.